Thank you both. That was fantastic. We are running a bit late. I think that's a testament to all the discussion and questions and so on that's going on. But we'll move ahead, and there'll be a short break shortly. So as we've heard a couple of times today, sepsis is heterogeneous, has many faces, and in particular in very young patients and very old patients, it can present quite differently. So we've just heard about the very young patients, and we'll move on to the other end of the spectrum, to older patients. So next I'll invite Hugh Boyd, who will be speaking about sepsis in an aging population. Dr. Boyd is employed as a care of the elderly physician, as the Chief Medical Officer of Sienna Senior Living Canada, as the Chief of Staff of St. Joe's Health Centre in Guelph, and the Medical Director of St. Joe's Villa Dundas. As an adjunct assistant clinical professor at McMaster University, a past chair of OMA section of LTCCE, and a past president of the Ontario Long-Term Care Physicians, he's advocated for modern quality indicators, person-centered care, and clinician resiliency in long-term care. Dr. Boyd.
Thank you very much. So a huge passion of resiliency in healthcare professionals. So I'll just invite everyone. I know you're late, but I promise I don't have a lot to say, so I'll help you catch up. But why don't we just take a brief moment to do a mindful minute, just to pause, reflect, and think about how you're doing. So how we typically do this is you can close your eyes, you can keep your eyes open, do whatever you want, whatever you're comfortable, and just pause and just try to feel, listen, hear, smell. And take a deep breath through your mouth. And just feel that healing oxygen going into your lungs and then going out again. And take another breath, and this time hold it for just a second. And feel that healing oxygen actually spread through your arms a little bit, through your shoulders, maybe going down your legs as well. And then breathe out. And next, take one more deep breath all the way in. Hold it. And then take an even deeper breath, a little bit more. You can do it. And hold it. And then just let it out again. And when you're ready, you can open your eyes. And we'll talk about something really exciting. So thank you for the opportunity. I was invited last week to speak on this, and I don't think I can do your previous presenter justice. I'm not quite the expert clinician or researcher, nor am I not as thoroughly informed about the immune changes in the elderly. So I'm going to go a little broader. I promise I'll touch on it, I promise. But we're going to talk about other things that I am feeling ambitious about. So I was very intimidated to come here, and then I thought, I can get something out of this. So I'm very much looking to develop partnerships, explore ideas for future research in this very important idea. So I'll talk about my disclosures, which is nothing to do with pharmaceutical companies or device manufacturers. I over-disclose, I get it. I get money from OHIP, and I get money from, you can go to the next slide, from Sienna, from St. Joe's, from Guelph. Oh, do I do it? Yes. Nope, someone did it for me, thank you. And I sit on a few advisory committees, none of which kind of influence anything earth-shattering money-wise, but trying to change the system, one little bit at a time. So we have some learning objectives. We're going to talk about the understanding of aging, normal aging on the body system. We're also going to talk about what is not normal aging and the unique challenges regarding sepsis. This is probably a common theme you're hearing. I do want to explore some innovations relating to sepsis and long-term care, and the big reason I'm here is I want to brainstorm with you topics for future research, areas where we could make a difference, we could move the needle, we could actually change the world a little bit at a time. Normal aging, there's a lot of things that happen and my geriatric colleagues will laugh at this very brief and infantile description, but I tried to narrow down a few things that relate to sepsis to try to explain some of the challenges we face a little bit later. So it's not exhaustive, but certainly, everyone knows about kidneys. Up to 50% reduction in functioning glomeruli in those 75 to 75 years old. That's common knowledge. That's not even people with chronic kidney disease. That's just normal aging. So that's the one everyone knows about. Everyone also probably guesses around heart changes, the right atrial volume increases, the left atrium enlarges. We certainly see a significant decrease in the maximum heart rate. That's common knowledge as well. And the left ventricle stiffening and hypertrophy that happens with age, probably due to the aorta stiffening and other cardiovascular changes as well. The big one relevant for the last 3 years is around the lungs. And certainly you're probably already aware about the changes in the elastic tissue and the collagen fiber networks, which results in decreased surface area for gas exchange. There's a really cool poster out there talking about the tight junctions in rat mice, of older rat mice versus younger rat mice, so neat to see that as well. We may find that similar in humans one day. We see that the surfactant and alveolar fluid contain a lot more pro-inflammatory proteins. And the big one that is a bit heartbreaking is the lung angiotensin converting enzyme 2 expression increases with age. That's that stupid receptor that SARS-CoV-2 attaches to. And we saw just a horrific tragedy of that over the last few years. We're also seeing greater ventilation perfusion mismatching. Increases in the alveolar arterial oxygen gradient. It makes sense if you think about it. The dependent parts of the lungs are sometimes closed during the respiratory cycle, so sitting versus supine makes a huge difference in ventilation. And of course, the stiffer chest wall results in greater reliance on abdominal muscles, while at the same time, the diaphragm tends to flatten and becomes less efficient with age. It's kind of a tough battle as we get older. Great. And probably another common knowledge, the urethra is less effective barrier to bacteria. There's a lot of sarcopenia, up to 30 to 50% non-linear loss in muscle mass, so it gets even worse quicker with time. And in the brain, most people know about the loss of white matter and gray matter, the decreased cerebral blood flow. And the frustrating thing, for specifically to sepsis, the neuronal loss tends to be the greatest in the cerebellum and the cerebral cortex. Those parts that we need the most in rehab are already at risk. Skin, obviously a lot of skin changes evident just by looking at someone who's 90, the obvious atrophy and decreased elasticity, but more specifically the epidermis is thinner and that dermo-epidermal junction is thinner. And that's one of the key factors which makes older adults, their skin so fragile to shear injury. Or when you put adhesives on them, it tears off part of the skin as well. It's not so much the skin, it's that layer. So these people take a lot more time to care for without hurting them more as well. And just a kind of note about, I'll talk a bit more about the decreased bone marrow mass and what that does. But the chronic low-level inflammation that's just common. There's just this pro-inflammatory state that exists. Obviously, with some of the factors that I talk about, the platelets are more responsive, and we think of this as older adults as being a kind of pro-thrombotic condition. So things you probably already know. So I'm not going to go into what sepsis is and what the different stages are. I'll dive quicker into probably the big reason they wanted me to talk about, which is the immunosenescence. And this is the idea that the immune system changes themselves that occur over age. And it's super complicated, and I'm not going to touch on all of it. And I'm not going to be able to get all the pathways well either, because while I was a bit of a immunology nerd in undergrad, it's been so long. So I'm gonna try, but bear with me. So I mentioned about the decreased bone marrow mass. There's a lot more fatty inflammation in the bone marrow, so it's less functioning bone marrow, but it's still there. So unfortunately, it does take a lot longer to replenish losses. So when someone's hemoglobin drops, the bone marrow just doesn't respond as quickly, making rehab that much more challenging too. But of course, we do see a decrease in the number, the diversity, and the proliferation and function of T lymphocytes. We see a decrease in macrophage precursors, specifically in the bone marrow. And surprisingly, though, the natural killer cells that secrete the cytokines and who destroy those virus-infected cells actually increase with age. So it's not all bad news here. We can grow old with comfort. And then more bad news. There's a decrease in CD4 T cells, an increase in, decrease in the co-stimulatory molecule, CD28, and that ultimately results in an impaired ability of the T cells to proliferate and to secrete IL-2. And a reduction in the CD4 helper cells also results in a reduction in the B cell proliferation. And then looking at our kind of humoral immunity side of things, there's certainly a decrease in the pro-B cells in the bone marrow, and when they study also see a decrease in the B cells in the bone marrow, and not surprising, we see a decrease in B cells circulating in the blood as well. But the really ticker part is there's a decrease in the diversity of the B cell and T cell repertoire as people age. And this is significant. They're less responsive to stimulation in older adults. You've probably heard of how obsessed we are with giving older adults like 1,000 COVID boosters, whereas most people were not so aggressive. And so that response isn't as strong as they get older. So it's harder to develop those memory cells as you're older. But interestingly enough, the memory B and T cells, when they're developed earlier in age, are very resilient to this. How many of you were there front line for 2009 H1N1? And do you remember how older adults did okay compared to middle-aged people? We were obsessed with the middle-aged people who were really struggling, and older adults tended to, I mean, proportionally they still got sick, but their illness is not nearly as much as we suspected because they had immunity. So one of the things we're obsessed about in terms of older adults is actually vaccinating children and adults and keeping those vaccinations going because it's really hard to do later in life. So I was really hoping, I didn't advance this, so sorry. Oh, there we go, someone did it for me. I suspect Ms. Anders and Dr. Schoenfeld would agree children are not just younger adults. I remember doing this in pediatrics. Kids are not small adults. They're completely different organisms. Okay, cool. Older adults are also not just older adults. So we talked about normal aging, but how many of you have someone in their ICU with only one past medical history who's over the age of 80? No. So you have aging compounded with multimorbidity. You have it compounding with polypharmacy, and they've been putting up with drug interactions and side effects for a while until they get sick, and then that kind of puts them over, and they're feeling some of those interactions more. And then the big thing I want to emphasize is around homeostenosis. And geriatrics is way more complicated than this. Again, please don't attack me. I'm not doing it justice. But homeostenosis is the big thing relevant to sepsis because most of us can tolerate fluctuations in lots of different parts of our body system. And in SpO2 and blood sugar levels, we can handle that. But as we get older, we can tolerate those changes a lot different. And that homeostasis is narrowed as to what we can tolerate. So they're higher risk for bad outcomes. So they're harder to keep alive. They're harder to keep from decompensating because they just can't tolerate those shifts as well. There's some really interesting Canadian research around kind of explaining this. The whole concept of frailty has been explored, I think, the best in Canada, to the idea of accumulation of deficits, is that someone isn't just frail because of age. We have the saying, chronological age is just a number. Frailty, where you pick up a little deficit here and a little deficit here, and your hearing's a little bit off, and your sight is a little bit off, and your sensation's off, and your white cell count is a little bit, and you accumulate these deficits, it's scary how much you can predict morbidity and mortality just by those deficits alone. So there's good reasons around it. I missed a great opportunity. Maybe I did. Maybe someone's still here. But I did want to do a shout out, just in case any of the authors from the Surviving Sepsis Guideline are here. Just bravo. The amount of work that it would have taken to do such a thing. There's so many researchers. How you guys came to consensus blows my mind. But you also did understand the importance of looking at things through an elder lens as well. And that's not common in guidelines. I can tell you, we get really mad at so many guidelines out there who ignore older adults as part of their population. No doubt pediatrics feels the same. No doubt there's lots of other groups that feels the same. But kudos, because there were very specific things relating to older adults in the management of sepsis. The one that I found the most interesting, and I actually learned, because I don't treat sepsis, I have to be honest. I manage the consequences of it. But they did, there was this neat research study about with 2,400 people all over the age of 65, and they did this permissive hypotension approach, aiming their mean arterial pressure for 60 to 65 versus the usual care. They didn't quite make it to 60 to 65. The research study actually ended up having an average of 66.7, but versus 72, so it was, allowed a bit of hypotension. The 90-day mortality was similar. 41 to 43.8%, so pretty darn close, and less exposure to vasopressors, both the duration of infusion and the total doses that they got. So they said, you know what, this is allowed, it can work, and we should be okay with it. All right, I'm going to move along. Thank you. Among the older adults, and then there's some neat parts around discharge. Follow up with a family doctor. Emphasis on the importance of home care with this as well. On my next slide, don't worry so much about cognitive improvement in older adult population. It doesn't seem to work. It does with younger people. And then, of course, with the older adult population, definitely referrals to rehab programs is important for those surviving sepsis. And so wonderful to see, beginning to kind of end discussed and identified within that. So I'm going to burn through this because no doubt you're probably sick of hearing how crummy QSOFA is and Muse and News. And guess what? In the older adult populations, it's even worse. So yeah, no one has a great diagnostic criteria for sepsis. We're just kind of, laying our hand on and sensing it, I think. Which is funny, I first became a physician in 2008, and as a resident, the first patient I had actually died of sepsis, and I was the last physician to see them awake. I actually got summoned to the hospital for a review committee, but they looked at my notes and thought, telling Allison before this, I've always been obsessed with vital signs. I take them all the time. I have a little tracker for respiratory rate. And I became obsessed with SIRS after that. And of course, SIRS has been replaced by a few different views of that. So we struggle with the diagnosis. We struggle with predicting mortality in this population. Certainly those who are institutionalized, that means long-term care facilities, are at higher risk of mortality, but also those with more dependent activities of daily living, more cognitive impairment, more multimorbidity, not exactly surprising stuff, but stuff that's relevant in terms of what we're going to talk about here. So innovations in long-term care. So I'm not sure if this group is aware, I just learned of this last year, that the palliative care zeitgeist has shifted away from advanced care planning. We still do it for code status because it's the one legal thing in Ontario. You absolutely can advance care planning, but I was obsessed from 2010 to 2019 about advanced care planning. I was teaching people how to do it. I invested hours and hours and hours in it. Turns out a lot of the research is saying it's a waste of our time. So we're shifting towards focusing on goals of care, and this is a hint because this is where I want your help in the future as well. So you're probably well aware of the Serious Illness Conversation Guide. I walk the walk and talk the talk. I only use it as a teaching guide, so if you have students, residents, etc., who have not the strongest emotional intelligence, you can literally read this one line at a time, and I've done it. We sit on the phone, I have this giant thing in front of me, and we read it one line at a time, and I've gotten someone to go from full code, do everything ICU, etc., to allow natural death and stay at home with hospice care only. And you don't pressure, you don't push anyone, so there's no risk of someone saying, are you trying to kill my mom? No, we're just listening, and we're empathizing, and we're actively validating your feelings. The other component, post-acute care and long-term care, there's some evidence around what we could do. It's not strong. In this particular research, there's only 691 candidates. They only found, they didn't found any significant difference in the outcome measures. There was a bit, like there was a trend, but not really statistically significant. And they only accomplished 3 differences in their process measures. So still struggling to figure out what does that perfect post-acute care look like. And of course, you're probably well aware that long-term care has received a phenomenal amount of pressure to treat more serious infections in long-term care. I'm trying really hard to take deep breaths before this meeting. I was worried I might bump into someone who's been involved with the, I'm not going to mention that. I'm short on time. Anyways, so we are doing more. We are using intravenous antibiotics, using intravenous fluids. We are doing our part. We have been for some time. So if you think Gomer, get out of my ER, is tolerable, it's not tolerable anymore. It's ageist, it's discriminatory, and it killed a lot of people in 2020. So we're doing a lot, but we don't have blood work every day. We don't have x-rays every day. I can't get a lactate in the community. So how on earth can I adequately figure out when to transfer this person to the hospital? I need help. So the research says we're probably going to do a horrible job of detecting sepsis. A complete set of vital signs only occurred in 66 to 74% of people prior to transfer to hospital from a long-term care home. So a chunk were being transferred without vitals. That happens. I see it. It's frustrating. And so a physician, nurse practitioner, or a physician assistant, and this is in major centers where they have them there every day, only assess them in 16 and 19% of the time in the 12 hours prior. In the 12 to 72 hours, same percentage. So we're not getting to them quickly enough. And of course, I'm going to poke a little bit here. Those with sepsis were more likely to return to long-term care on antibiotics. And funnily enough, those with sepsis were less likely to have a diagnosis of a UTI. Because asymptomatic bacteriuria doesn't cause sepsis. And we need to stop throwing antibiotics at asymptomatic bacteriuria. Anyways, we'll get to the last part because I do really want to get into questions around this. I'm interested in exploring future collaborations. It warmed my heart to hear long-term care retirement homes identified as possible areas to explore further with. We are a teaching center of the future already. We teach people a lot. We are expanding our research capabilities. We have some remarkably well-developed research networks already working within long-term care. None of them are sepsis experts. And so is there a chance to look into things like artificial intelligence assisted goals of care? Looking at things like SIRS or, all the old pneumonia things worked well back in 2010 and 2008 when we had our Palm pilots. We were obsessed with rules that had 5 or 6 criteria. But guess what? Humans aren't that complicated. We have the machines that can assist us to compensate through, 1,000 variables. Because in the nursing home, I have 1,000 variables on each of my residents. We have the machinery that could help us analyze that and make informed goals of care predictions, like they have a 27% chance of surviving if they get sepsis. That's probably meaningful for a substitute decision maker. I know it is. They ask me that number, and I have to tell them I have no idea. I'd love assistance. Could we look at improving vitals monitoring and using AI, as Allison's doing, to try to anticipate who are the people who are at risk? Well, we got to get them first, but then we'll use AI. Can we improve, of course, target assessments and looking at best practices, as I hinted at, for post-sepsis rehabilitation, long-term care? These are just my ideas. I walked up here with a pen. I'm very interested in writing down ideas other people have and either stealing your ideas or collaborating with you to explore how we tackle this, because we have a captive population. There are thousands of people living in long-term care, and we are collecting hundreds of data points on them automatically every 3 months. That's just Ontario. We also have the rest of Canada. So we have data we're already collecting. What can we do with it? So I'll leave it there, and I'm very interested to hear any questions you have, which I probably can't answer, but also interested in hearing thoughts about future areas we could go in. Thank you.
This might be probably more of a comment than a question. Ryan Perry with CIHR. Were you or are you familiar with the Long-Term Care Plus program that was funded and led through the Institute of Aging?
Yes.
Because that will be a network of groups, and maybe another, had me thinking of other groups to connect Healthcare Canada, right, about implementation of practices or effective practices in different settings. And so there's other networks that you can lean on, such as the Long-Term Care Plus groups that were really about implementing evidence in practice. But the long-term care community is you have the private and the public environment that causes some challenges as well.
And great comment. Thank you very much. I wrote it down. Wonderful organization, very Toronto-centric, I'll note. Having trained in Toronto, I had to break that mentality a little bit, but there are other research networks as well. So McMaster and Schlegel institutes have teamed up. We just signed through Sienna Senior Living, a for-profit, giant, mega for-profit corporation. They're so evil. They're not. They're actually participating in this research, and we're hoping to collaborate with Schlegel, which is also a for-profit organization, and countless other not-for-profit organizations as well. So we're ripe. We have a number of, well, 3 decently developed research networks. But we need some PIs who have an interest and passion around sepsis, and we have a lot of data. Thank you for that comment. Appreciate it.
I'm going to have to be the bad guy.
Yeah.
Cut it short. Thank you so much for that.
Yep.
Just to give people a chance to have a little bit of a break. So